Okay. Well, welcome everyone. So glad that everybody could be here, especially Dr. Sarah Beal. So today we have the pleasure of welcoming Dr. Sarah Beal, an associate professor in the Division of Behavioral Medicine and Clinical Psychology at Cincinnati Children's Hospital and in the Department of Pediatrics at the University of Cincinnati College of Medicine in Ohio. She is also the scientific director for the Comprehensive Health Evaluations for Cincinnati Kids, the CHEC Foster Care Center at Cincinnati Children's Hospital. I was excited to come upon her work, not only because of our overlap in geography, both of us have now lived in Ohio and Nebraska, but also because she's filling a critical gap in our evidence-based research regarding foster youth and the health and healthcare disparities they experience and how these experiences affect adolescent development and health. She received her PhD in developmental psychology from UNL, and so we're excited to welcome her back to her alma mater to present on all of the impactful work she's doing. If you have any questions during her talk, please use the chat box and we'll have Sarah answer any questions at the end of her talk. Thank you very much, Sarah, for being with us today.
Thank you so much for the opportunity to be here. I'm really, really excited to be back at UNL, even if it is virtual. While I can't see all of you right now, I'm looking forward, once we're done with the slide presentation, to have some really good discussion with you. So my goal is that we'll have about a half an hour to 45 minutes at the end of this to jump into some of those discussions. I'd like to start by acknowledging that I have built this career on a foundation I received at UNL 10 years ago. And so I'm really excited to be able to celebrate the work that I've been able to expand upon from my start with Lisa Crockett at UNL and Vicki Weiss at the Center for Children, Families, and the Law, who really helped to give me the foundation that I've built this work upon. I also am very, very blessed to have incredible colleagues, including Mary Greiner, who's the medical director here at the Foster Care Clinic, and numerous other faculty and staff that have supported me, our close relationship with Hamilton County Job and Family Services, and some funding that's been able to support this program of research. So to give you a brief overview of the talk today, I want to start off with some discussion of the intersection between child welfare and healthcare systems and understanding that groundwork and where that might help us to understand and have some insight into mechanisms that are driving health disparities for this population. And then talk about three separate studies that we've done. One that's really focused on healthcare access and use for this population of young people in foster care. A second, looking at identification of health concerns and how we address that in the healthcare system. And then third, coordination across stakeholders. And by the end of this talk, I'm hoping that I've convinced you that we really need to have an integrated understanding of individual health needs and healthcare service access, and also how healthcare systems are delivering services to identify and meet those needs, as well as communication across stakeholders to really actually address and change some of the health disparities that we see with this population. So for some brief background, on any given day, we know that about 424,000 children are in foster care in the United States, which is about half of 1% of the total population of children living in the United States. But if we expand that to over the course of a year, so a child that's been in foster care at least one day over a 12-month period, that extends out to 672,000 children, or 1% of the US population. And if we look even farther, over 18 years of a young person's life, then we get up to roughly 4.3 million, or just under 6% of the US population that will touch foster care before their 18th birthday. So while we tend to often think about children in foster care as a very small subset of the total population, when we look at adults, we know that there's a non-ignorable proportion of the United States that has experienced foster care at some point during childhood. There are disparities that we need to be looking at and paying attention to in who comes into foster care. So the risk of entry into foster care is not evenly distributed across the US population. We know, for example, that our Black and Brown children are much more likely to come into foster care than white non-Hispanic populations, and that individuals that experience poverty are more likely to come into foster care than those that have higher socioeconomic status. So there are already disparities related to social determinants of health and other concerns that exist before young people enter foster care that's going to impact their health. There are also multiple federal, state, and local policies that manage the administration of child welfare and support child health and healthcare access while young people are in foster care. Specific to health and healthcare access, children are federally required to interact with healthcare systems at the time they enter foster care and then annually thereafter. And that initial interaction with the healthcare system is really required for the purpose of identifying evidence of maltreatment, so child abuse and neglect, and also identifying risks for communicable diseases as young people are moving out of their family of origin and being placed with a new family of origin. But there's some important changes that we can make, and I'll get to this in a few minutes, around how that health policy plays out at the local and state level that can really help to support better health for young people in foster care. And compliance to these federal recommendations is audited through a review process that happens every year with funding for child welfare tied to compliance with those requirements. So despite all of these policies and services and supports in place for young people when they come into foster care, we know that health concerns persist. So this is a layout where blue represents data from populations of young people at the time they're coming into foster care. Green is work that we've done while children are in foster care, and then red, the red or pink bar represents when they've exited custody. And what we see is that across a variety of different types of conditions, concerns persist across this. So it's not an instance of young people initially coming into foster care, receiving services, and then those health issues being resolved. They're really persisting across the lifespan. And some of the way that I've thought about this is influenced by my own training in developmental psychology. And John Schulenberg and Julie Myslowski published a paper in 2015 that describes different perspectives of how we can think about the role of adolescence in the health course or in the life course that I think are also applicable to thinking about what's happening around health for young people as they're moving through the child welfare system and beyond. And the first is this shot out of the cannon approach. So that's this idea that early life experiences, adverse childhood experiences, or social determinants of health that happen early in life sort of set the stage for a trajectory of health that we're going to see unfold early or later on. So that what happens when you're young really is most influential for determining the overall health course or life course in the case of this paper around adolescence, whereas the second model is the contact sport model. And so that's where you're thinking about a young person interacting with different systems and those systems changing their overall trajectories, but they also changing their course, right? So that they're asserting some influence. And I think that provides different perspectives on when we should intervene and how we intervene that are important when we think about research related to the health of young people as they move through foster care as well. So for example, maltreatment histories often predate child welfare involvement in out-of-home care. And we know that exposure to maltreatment and adversity establishes impact that's going to unfold into adult life. So that those early experiences are really influencing how we see cardiovascular health in adulthood, risk for other diseases as individuals move across the lifespan. And so it's possible that what happens early on is influencing what we see in an overall trajectory that's going to be difficult to change. And so in that model, we might expect that there's going to be some factors that young people come into foster care with and that are going to persist with them across their life course. And we need to design ways to support, but that we're not going to be able to change those trajectories of. Alternatively, we know that youth and families are interacting with and shaping their experiences in child welfare and with the healthcare system that are going to alter their own health. So how frequently they seek out healthcare, whether they follow up on services or not, whether they're adherent to treatment recommendations, are all going to shape what happens with their health overall. And we can leverage those dynamics to be more beneficial. So if we capitalize, for example, on agency and independence in adolescence, we might be able to create opportunities where young people can assert themselves a little bit more independently and be more successful in managing their own health care. And I'll talk about that a little bit more later on. But we need systems that are designed in ways that can interact with youth to support and bolster better health that specifically account for this experience of coming into child welfare and moving through the child welfare system. And right now, our healthcare systems aren't designed to do that. They're designed for the general population. And so that creates some gaps that we really need to address to understand health with this population. Another model that the Center on the Developing Child has put out, which is adapted from Bronfenbrenner's socio-ecological model, really focuses on these different components of systems that are going to influence health and development across the lifespan that are important to consider. And so we know that there are lots of different policies, decisions, access to resources, community characteristics that are going to influence how young people can access health and how well that healthcare system is designed to improve their health over the life course so that young people are not equally able to access the kinds of health services across all the settings that they're in. So you can think, for example, about differences between kids that live in urban settings and might have access to systems like our academic medical center here at Cincinnati Children's versus kids that live in more rural and impoverished settings and don't have access to that kind of healthcare, and how that's going to change their experiences and their health trajectories overall. But we also know that there's interactions between these different systems, right? So the young person is changing over time and influencing their own development. And we also see that child welfare and healthcare systems are interacting with caregivers and education systems. And that interaction is going to also shape these differential trajectories of health. So it's important for us to account for the fact that these systems are interacting with one another and influencing the young person in different ways over their life course when we're trying to think about how we develop systems that are going to effectively address health disparities for this population. There are a couple of local policies, I mentioned this earlier, that we have federal, and then we have opportunities to expand on that with state and local policies that I think are important when we think about child welfare and health disparities in particular. And I'll use two examples with in the state of Ohio, but I would point to, for those of you that haven't had the chance to read it yet, the political determinants of health as an example of how we can think about the interaction between policy and what happens with legislation and how that drives some of the social determinants of health and health disparities that we see across the United States. So in the state of Ohio, there's Ohio Revised Code that expands upon the federal regulations to require that children have to be seen by a healthcare professional within 5 days of their entry into custody. So that's addressing that initial requirement, but also that with every placement change, they have to revisit that a healthcare provider. Now, what our local community in Cincinnati did, which is an expansion upon that, further refining that state policy, is that they said that instead of allowing a new caregiver to take a child to any healthcare professional, and that's an RN or advanced in training, so it could be a nurse who is a neighbor and is willing to give a brief exam for that child, or an urgent care clinic, for example, or something that's in your grocery store, that our local community said that they wanted that healthcare delivered by Cincinnati Children's. So in Cincinnati, we have a policy that says that when a child is coming into foster care or experiencing a placement change, they have to come to our foster care clinic for those change of placement exams or at the time of entry into custody. And we're seeing more and more specialized foster care clinics pop up across the country. We have one in Omaha, for example, that's opened up and that's providing similar services. So there's opportunities to leverage those kinds of things, but there's also opportunity to build policy that enforces and encourages families to access these services where we think that there can be better healthcare delivery and care coordination. And what this kind of expanded policy allows for is that as children change placements and are with new caregivers, the health information that's been gathered and the evaluations that have happened over that previous placement can be communicated to the new caregiver so that there's better continuity in healthcare. Without those kinds of interventions, kids come from one home to another, and you can lose some of the health history that they would have if they had been with a continuous caregiver and a continuous healthcare provider over time. So with that in mind, I'd like to talk a little bit more about 3 different buckets of intervention and questions that we've had in understanding these systems and how they might be contributing to health disparities. First, individual health issues and lack of healthcare access and how much that might be driving what we see in health outcomes. Second, how healthcare is delivered. Third, communication across social supports and stakeholders, with the goal that eventually by understanding all of these different dynamics, we can really understand what's driving differential health outcomes for this population and how we can address the health disparities that they experience. So first, is the problem a lack of access to healthcare? And I think this is a legitimate question, right? Because if in reality we can't get kids to be seen or they can't get seen at the right places, then no matter what kinds of other interventions we put in within a healthcare system, we're not going to see any change in health outcomes. For a little bit of context about the study that we executed to understand healthcare access, health risk behaviors, and child welfare involvement, we did this study with Hamilton County, which is where Cincinnati Children sit. I've highlighted it in blue here at the bottom. So it's right on the border between Indiana and Kentucky, but sits in the state of Ohio. We're a county administered system, much like Nebraska. So each county can make its own additional policies that comply with federal and state policies, but they're allowed to administer their own child welfare system. So there's lots of variation across the state of Ohio in how child welfare is administered and managed. Hamilton County Job and Family Services holds roughly 2,000 children in custody on any given day. And we have extended foster care to age 21 while I've been here in Cincinnati. From a healthcare standpoint, we have the foster care consultation clinic that is directed by Mary Greiner. I've put her picture there. She's an incredible collaborator, and I'm so fortunate to have had the chance to get connected with her early on when I arrived at Cincinnati Children's. Cincinnati Children's is also the only healthcare system for pediatrics on an inpatient standpoint, and that's both for physical health and behavioral health. So all kids that need to be admitted to the hospital for either mental health or physical health concerns are transferred here to Cincinnati Children's. And then we're the primary outpatient provider for all specialty care. That's both private insurance and Medicaid, and the primary provider for primary care for those that are enrolled in Medicaid. So we have a pretty good coverage of healthcare delivery across our community for children that are in and out of foster care. The Careful study linked 2,787 children's records from our Ohio SACWIS system. So that's our state child welfare information management system. All of those children had been in foster care for at least one day between 2012 and 2017. We were able to link to their medical records and had 25 young people who fell within that criteria that didn't have a matching medical record and were excluded from the study. And I can have a whole separate conversation about how you link these kinds of records. If anyone is interested, feel free to reach out to me. We included young people because of our focus on healthcare utilization and health risk behaviors, included young people who are between the ages of 10 and 20 inclusive. Our population matched what we see in the child welfare population in our local community. So roughly half were female and 65% were African American. And what we did was identify a matching comparison sample of young people who were never in foster care in the state of Ohio and were seen for primary care in our healthcare system around the same time, so that we could ensure that we were getting similar health information as what we would expect for the foster care population and could really look at health risk behaviors and health outcomes. All of the young people in our comparison sample were insured by Medicaid so that they had similar socioeconomic and insurance types across our two groups. And they were matched one-to-one on date of birth within 6 months, as well as gender and race and ethnicity, so that we saw similar demographic characteristics across these two populations. From the Child Welfare Administrative Database, we were able to determine whether young people were in foster care during the time of each of their healthcare encounters. And that was important because I really wanted to isolate what was happening around healthcare utilization when young people were actually in foster care as opposed to before or after they were in child welfare. And there's a whole separate amount of work that we could do looking at that continuity over time, but we focus here just on the time when young people were in foster care. We had the information about their age of first entry into foster care so that we could control for the effects of long-term involvement with child welfare. Reasons for entry into foster care, so whether they had experienced abuse or neglect or some other factor that contributed to their foster care involvement. Their placement type, which was important for thinking about the effects of stranger care or being in a licensed non-relative foster home versus kinship care versus other types of congregate care settings. And then we also had indicators of placement stability. In the electronic health record, we were able to hone in on type of healthcare encounter. So was this a primary care visit, a specialty visit, an emergency department? We also were able to use that information to understand how old they were at the time of that healthcare encounter and how and when that timing happened related to when they came into foster care or experienced placement changes. And I'm not going to talk about those data today, but that brings another interesting perspective on what's happening with healthcare that I'm happy to talk about later, if anyone's interested. We had their diagnoses, and that's both mental and behavioral, or mental and physical diagnoses, and we can calculate their complexity or disease complexity and severity from those diagnoses. Their demographic data, and then their sexual risk behavior and substance use were the two health risk behaviors that I looked at here. With the exception of those two fields, all of this other data came from structured data fields. So that's where somebody typed a checkbox, or somehow there's a drop-down menu, something that really gave us a structured insight into what was happening with them. But with substance use and sexual risk behavior, we actually reviewed all of their medical notes, so their clinic notes that came along with those healthcare encounters to extract that information. And I'll talk about that data in a little bit. So what you're seeing here is the distribution of healthcare utilization controlling for mental health diagnoses, physical diagnoses, severity of physical diagnoses, race and ethnicity, gender, all of those things. How frequently young people are using healthcare over the 10 to 20 year age range that we were studying. And again, the light gray is young people in protective custody while they were in protective custody, compared to this dark gray, which is the young people who were never in foster care. So we look at these data, and what that would suggest to us at first glance is that young people are using more healthcare when they're in foster care, in particularly more emergency and inpatient care. They have slightly more missed visits, maybe a little bit more primary care, particularly in this middle to late adolescent period, and more specialty care. And so at this first glance, we might say like, nope, it's not a problem of healthcare access. That's not what's driving these risks. But when we considered health risk behavior, we saw a very different picture. So instead, what we saw was that actually young people in foster care were using less healthcare once we accounted for health risk behavior, compared to young people never in foster care. And we didn't see any difference in emergency or inpatient admissions. We saw less missed care, but also less primary care. And this was the significant difference that was driving differences in total healthcare use overall. I should have mentioned earlier, this excludes foster care clinic visits, because that would automatically bias the count of healthcare utilization. So foster care clinic visits are excluded from all of these data. And so what this shows us is that actually there are some disparities in healthcare utilization, where those young people who really need the most health care based on their health risk behaviors are not necessarily accessing it. And there's this interplay between healthcare access and health risks with this adolescent population. We also see that these health risk behaviors are changing when we're observing changes in healthcare utilization, so that really this early adolescent period might be an opportunity where young people are using more healthcare services and accessing those services when they have higher healthcare risk, or once we control for higher healthcare risk. So in summary, healthcare access and use appears to be complicated by health risk behaviors that might be explaining some of the disparities and differences in healthcare utilization, as well as higher healthcare costs for young people in foster care. We know that there are opportunities for prevention and intervention among patients with these higher health risk behaviors, but it looks like this increased overall contact with the healthcare, but that explains the increased overall contact with the healthcare system while youth were in foster care. That there appears to be an importance for early adolescence, which is an important area for prevention and early intervention. And that it could be that some of these disparities, particularly in primary care access that are interacting with health risk behaviors for foster youth, could be what explains the higher cost of healthcare that's delivered for this population of young people. So the next question that we're going to move on to is whether the healthcare system, so when I say we, I mean healthcare, that's where I said, do we capture and address those health risks when those young people are seen? And this was really important for me, particularly with respect to substance use, because we know that substance use is more likely to occur among foster youth and former foster youth than what we see in the general population. But interestingly, there aren't strong guidelines specific to foster youth or to child welfare around substance use screening and prevention with this population. So we again here use the careful study to understand what was happening with screening for substance use. This distribution, or this graph, is representing all young people that were seen for healthcare that were part of the careful study, so both foster youth and non-foster youth. And this graph is showing the proportion of young people who were never screened for substance use the whole time across this 5-year period that we observed, where we see roughly 1 in 4 young people that were never asked, or at least it was never documented in either structured or clinic notes, so those unstructured data around their substance use. So 75% were screened at some point. And of that screening, about 40% was positive. But what we did notice was significantly different is that positive screening results and the occurrence of screening was much more likely to be documented in unstructured data compared to structured data. So that means that clinicians are asking young people about their substance use. And even though there's a place to put that in the structured data in the checkboxes, they're not putting that information there. They're actually writing it out in their clinic note. And so when you pull structured electronic health records data, which is what's most often used with our healthcare systems and in health services research, we're missing a lot of the information that we need to really understand what's happening with health risks in this population, because clinicians aren't storing that information there. And as I'm sure you can imagine, when we have a sample size of 5,787 young people, and we had a median number of healthcare encounters for this population of 10, so that's roughly twice a year over the course of their involvement in this study for healthcare encounters, that's a lot of clinic notes for us to review and code. And so I had the opportunity to work with Yizao Ni, who was at Cincinnati Children's at the time and has since gone on to Kaiser, to develop some technology that allowed us to use natural language processing to code some of those clinic notes so that we could successfully detect with fairly high accuracy when screening occurred and what the result of that screening was. So I told him that our requirement was that the sensitivity and specificity, so the accuracy from his performance metric standpoint, had to at least match what we try to do when we're establishing reliability among coders, which was 0.8, and he rose to the occasion. So that was fantastic and allowed us to cut down on some of the time that we needed to be able to code all of those notes to be able to look at some of this health risk behavior. What we found with those data was that youth in foster care were 3 times more likely to be screened for substance use compared to youth in the comparison cohort. So there's a higher occurrence of screening. Most of that screening was happening when foster youth were first coming into foster care or at mandated change of placement exams that were happening at our foster care clinic. And when we looked at differences between young people who were never in foster care, that's the dark blue line, young people who were ever in foster care but not in foster care at the time of their screening, and that's the green line here, or at the time of their not in foster care at the time of their healthcare encounter, sorry. That's the green line. And young people who were in foster care at the time of their healthcare encounter. So that's this pinkish line here. What we see is that there's similar patterns of past year substance use. So having used any substance in the last 12 months, between these groups of young people never in foster care versus those young people who are screened and are currently in foster care and reporting past year substance use. But that both groups are higher than the group of young people that were never in foster care. And then secondly, that those odds, which is not surprising given what we know about adolescent substance use, that those odds are not equivalently distributed across the age 10 to 20 age range. And we looked at this data controlling for all the covariates that I mentioned previously, for any substance use as well as for alcohol and tobacco use, and we saw similar patterns. But we saw a different pattern when we looked at marijuana. So what we saw with marijuana instead was that young people who were currently in foster care were significantly more likely to have engaged in marijuana use over the past year. And again, that you see sort of a steeper increase, but then a plateau starting between ages 16 and 19. So that's leveling off, and we see an acceleration that's happening before age 13 for these young people. So what that tells us is that with respect to substance use, and since then, my colleague Mary Greiner, who's very interested particularly in younger children, has replicated similar patterns of findings for things like developmental delay, is that we need to do a better job as a healthcare system of identifying and responding to health risks in order to reduce these health disparities. So with substance use, and she could give a whole talk about developmental delay, screening happens, but we could do a better job. So while we're screening most, we're not screening everyone. but documentation is really a problem. And so even when we're screening and detecting, we're not documenting it in a way that can be shared and acted upon by others, which is particularly important for this population because they are much more likely to use multiple healthcare systems rather than a single healthcare system. And there's no unified way of sharing those notes across providers. We also know that risks are shifting by type of substance, so that we see differences between marijuana and tobacco and alcohol use, for example, and that the type of substance, as well as their current and historical child welfare context and age, all matter. And so taking that into account as we're thinking about how to prevent or reduce substance use with this population is going to be important. And then finally, we've highlighted gaps in prevention and intervention. So we have the opportunity to take advantage of increased contact with the healthcare system in early adolescence, which we know is happening differentially by health risk behavior, and to take advantage of things like mandated foster care clinic visits to maximize the amount of people that are screened and action upon that screening. Where I'd like to particularly note that we ran into issues that screening at mandated visits, while they were occurring more often than for primary care or urgent care, never resulted in a treatment referral or diagnosis, even though we know that substance use disorders are higher in this population. So screening was occurring, but responding to that screening was not. And we're fortunate now to have a SAMHSA grant that's actually allowing us to implement standardized screening as well as brief intervention and referral to treatment to try to address some of those issues. So we'll be looking at that and seeing how that unfolds over the next 5 years. The third question and focus is really around how we communicate health information to those who could take action. So potentially one could argue that maybe it's the role of the healthcare system to identify the problem and the role of other systems to take action to address some of those problems, particularly when we're talking about things like substance use prevention, right? And I think it's important to keep in mind that when you're talking about the general population and how we design and deliver healthcare, we really put the parent and their child at the center of that. So the parent and child sit in the middle, and this actually aligns very well with Bronfenbrenner's model. And then these other social services, healthcare systems, schools sit around that parent-child dyad that's really at the center of those interactions. But what happens when a young person comes into foster care is that the connection between their parent and the child is disrupted, right? So now the parent moves from the center of that network or that hub to sitting on the outside. The child sits in the middle, and then we have a whole bunch of other services that come around that child. But those services are not interconnected with one another. So some of them might be connected to the parent, some of them might be connected to the caseworker, some of them might be connected to the caregiver, and some of them might be connected to the child themselves. And so when we talk about things like information sharing, particularly to address health concerns and health needs, we have to account for and figure out how we communicate effectively with these different systems. So that's what I'm going to talk about for the next couple of minutes, is some of the work that we've done around that. Specifically focusing on how the healthcare system, which is a system I sit in, so it's where I feel like my sphere of influence is, communicates with children, with their caseworkers, and with their caregivers around the health needs of this population. So I'm going to start with a quick discussion of a study that we did called I Care to Check that started with 5 foster care alumni who had emancipated from foster care in the 2 years before the study started, and were co-creators with me. So I had the chance to sit down with them and with Mary Greiner, our medical director, and basically say, tell us your experience about moving through and out of the child welfare system and how you access healthcare. And what they told us was, I don't know where to go. I don't know what to do. I don't know what symptoms justify me going to the emergency department versus my primary care provider. And when it's time for me to call to schedule an appointment, I'm not sure even what to say or who to call to figure out how to establish new primary care with a new provider. And a lot of these things are challenges that would normally be answered by a parent or through trial and error showing up at your university clinic for students, for example, but these young people don't have a lot of those resources. And so what they asked us to design with them, and we ultimately created, was the I Care Guide, which is a discrete guide that sits in their pocket that gives them scripts of things to say when they're calling new clinics, and guidance about where they need to go to access healthcare services. as well as places for them to document their own health information. And at the end of this, by the time we were done with this entire process, our local counties have chosen to ensure that that's provided to all young people as they turn 16 and are in foster care. So we now have a sustainable model for ensuring that these guides get out to all young people that are in foster care in our community. And so after we designed those guides, of course, we need to study them and make sure that they're actually helpful, right? Because we don't want to do a lot of things that end up draining resources and don't actually have any impact. So we enrolled 151 adolescents who were between the ages of 16 and 20, had been in foster care for 12 or more months and were expected to emancipate within the next 18 months. And we actually observed emancipation with 30% of the population. And we surveyed 3 times, so at baseline, 6 months and 12 months over that year, to assess their health risk behaviors, their healthcare access, and their transition to adulthood. And what we found was that the young people who received the guide used those healthcare guides for a variety of different activities, and the vast majority of them reported that they were in fact using them. So we had great uptake. But we were also interested in whether it actually changed their health outcomes and their connection to healthcare services. So we identified a matched sample who were demographically similar and were emancipating from foster care over a similar time period, and then used that health information, that healthcare access, over a 2-year period. So the year before all young people got the guide, and then the year following they're receiving the guide, to make comparisons between those 2 groups. So we ended up with 300 kids overall. And what we found was that first, healthcare utilization was decreasing as kids got older. And so this mimics that distribution that we saw early on in the very first couple of graphs that I showed you, where healthcare utilization is declining as young people approach their 18th birthday. But what we see here is the enrolled youth. So these are youth that receive the iCare guides in black. And the comparison sample, which is in this light gray, had similar levels of healthcare utilization in the year before receiving the guide. But we saw an increase in total visits, and particularly in the foster care clinic visits and their scheduled outpatient visits. So that would be for things like primary care and specialty care in the population that received the iCare guides compared to those that did not. So what this tells us is that there are ways that our healthcare systems can adapt and design unique interventions that are fairly low cost and easy to implement, that can help to ensure that foster youth stay connected to our healthcare systems, and that we can continue to support them. So the next question that we had was about caseworkers. So how well is our healthcare system communicating with caseworkers? And Mary gives a great talk, Dr. Greiner gives us a great talk about her experience establishing the foster care clinic and what communication between healthcare systems and child welfare systems are like. I'm going to show you some data about surveys that we collected with frontline caseworkers so that they could tell us their experiences on a day-to-day basis within the context of acknowledging that we have a really great foster care clinic visit here, and that people are working really hard to ensure that communication happens. And so we surveyed those frontline caseworkers, 53 of them total. That was 87% of an 87% participation rate for surveys that we sent out, about their access to health information for children on their caseloads at the time they were coming into foster care. So all of these questions are targeted specifically at the first 30 days that a young person has entered the foster care system. And our caseworkers told us that on average, so a median, because there was not a normal distribution of these data, they were spending 88 minutes trying to find health information for one child on their caseload, with a range between 10 and 400 minutes. And while they ultimately got all of the information that they needed, at least most of them did, that's that graph, this graph down here, where more than 75% reported that all of the health information was complete for all of the kids on their caseload that they were reflecting upon during this data collection period, that health information was not easy to access, and that they had concerns or had experienced missing information contributing to poor health outcomes, limiting their ability to support caregivers, and contributing to poor placement outcomes, like caregivers choosing to disrupt their foster care placement because they felt like they didn't understand the health needs of that child, and it was more than what they had anticipated at the time they agreed to take that child into their home. And so even though caseworkers had access to a foster care clinic visit in the context of the data that we're reporting on here, they still faced a lot of challenge with actually getting the health information that they needed at the time that they needed it. And so what we designed was a program called Identity, that shares and integrates information between the child welfare system and the electronic health record system. So it shares near real-time information between our social service system and healthcare system for children in foster care. It takes our Cincinnati Children's EPIC data and the SACWIS data, first at Hamilton County and now in a separate county and with a second children's hospital in Ohio, links that information and then displays it so that healthcare providers can get access to things like which caseworker should I call? Where does this child actually live now that they're in foster care? What Medicaid number do I access or use? And caseworkers can get information about what medications the child is on, what immunizations they've had, their diagnoses, the last pharmacy that can fill those prescriptions, all those critical health pieces of health information that they need to deliver better care to their young people. We launched that originally with 66 children's services staff and 10 clinicians in 2018. That spread to 346 children's services staff and 284 clinicians in 2019. And in 2021, we expanded to a second county and a second hospital. So that now, today, I checked early this morning, we have just over 3,000 young people that are represented in the identity system with linked electronic health record and child welfare data. And we had the opportunity to go back. So this paper is now under review, but to go back and use that data that we collected from caseworkers as baseline to figure out how we were impacting their care and workload. And what we found was that we had an 83 minutes saved on average in information gathering per child that was served. And then I had the chance to work with Linda Dinan, a health economist, to calculate what that savings was. And it contributed to pretty substantial savings for our Children's Services Agency across all the children and caseworkers that they have on their caseload. And now I'm excited to share that we've recently licensed that technology with Core Data. So that Core Data is able to expand to other healthcare systems and other states where we would not be able to do that with just the technology and expertise that we have within Cincinnati Children's alone. And so, like many of you, I figured if we've got this set up, we're telling caseworkers about what the health needs are for these children. They're using this system, they're reporting they have time saved, that the information is complete and there when they need it, that should trickle down to caregivers, and they should know and understand the health needs of young people that are placed with them at the time that they move in as well. And thankfully, Mary and I had the foresight to do some primary data collection with caregivers in the foster care clinic so that we could look at that and ensure that that was actually happening. And so what we did was design a survey where we would assess the knowledge of child health concerns that was specific to the child that had been newly placed with a caregiver that was administered before and after their foster care clinic visit at the check center. So 77 caregivers were surveyed before identity was implemented and had 70% uptake across caseworkers in Hamilton County. And then we surveyed 206 caregivers after identity was implemented. And what those caregivers told us came as a bit of a surprise. So while 50% of caregivers reported that they had received an identity printout that indicated something had been shared with them from the identity system, the information that was most important to them was not getting to them. And in fact, what the caregiver or the caseworkers was doing was printing off the insurance information so that they could share that with families, and families would have access to Medicaid billing numbers, but they weren't getting as much information as we would have liked about other things. Specifically, we saw no improvement in communication around upcoming appointments for that child, minimal improvement in communication around allergies, and minimal improvement around immunization records, which was not significant. And so from that, we went back and talked with some of our caseworkers and came to realize that while caseworkers were using identity, they were using them for their own workflow. And so using identity to communicate with caregivers specifically around the health needs of young people was not front of mind for them. And so now we're working on another platform, like another view of the existing identity platform that could be designed and delivered specifically to caregivers so that they can have access to that, similar to what we see with MyChart. For those of you that are familiar with the MyChart system and have children that access healthcare generally, but where legally healthcare systems are not allowed to provide MyChart access to foster kinship caregivers. And that's a whole separate discussion about where we can make policy changes around that as well. So with that in mind, I'd like to ultimately answer the question that I started with, which was how do we eliminate health disparities in this child welfare system and what we're seeing with these young people. And I think that through this course of research to date, and as I continue with it, I've come to settle on that we really need to have systems change where our healthcare systems and our child welfare systems are co-designed rather than being designed in silos, and where healthcare system is designed for foster youth rather than being designed specifically for the general population and not adapting to the child welfare population, so that we can do a better job of identifying individual health and healthcare needs, ensuring that our healthcare systems are able to identify and meet health needs for this population, and that we communicate that health information in order to see differential trajectories of health outcomes for these young people. And with that, I'd like to say thank you to all of you and to open it up for questions, but also thank the incredible and numerous collaborators that I've had across our child welfare and healthcare systems that have enabled supporting all of this work.